incredible. The good news is my flight's canceled back to Philadelphia, so I'll have an extra day to see Kansas City. But I'd like to talk to you. And again, this is going to be an overview of a variety of different areas related to sudden cardiac arrest. Now, I guess this is all working, and then I'll try it. And so the purpose of today's talk, and the pointer is at the middle. Okay, is to illustrate that sudden cardiac death is still a major health problem, and to describe the epidemiology, it went out, but I'll sing with it, to describe the epidemiology and etiologies of sudden cardiac death, to recognize the evolution of treatment and prevention of sudden cardiac death, and to review contemporary indications, including the guidelines, and how to apply them in clinical practice. So sudden cardiac death claims more lives each year than a combination of stroke, lung cancer, and breast cancer. Estimates range, depending on how you calculate it and where you read, between 184 to over 400,000 per year in the United States, representing 6 to 15% of the total mortality. Sudden death is estimated to account for about 50% of all deaths related to cardiovascular causes. Survival to discharge is less than 20%, even in the case of witnessed arrest. And survival, if you have a non-shockable, non-DT, non-VF rhythm, is much lower, 3% probably at most, or even 0% in some studies. Now, can you hear me? Because this is out. I could use this. Is that okay? If you look at the Framingham study during 26 years of follow-up in looking at the incidence of sudden death by age and sex in persons free of known coronary disease, you can see, as you might expect, that the incidence increases with age in both men shown in green and women in pink, and that women have about a 10 to 20 year lag in the incidence of sudden death, mostly related to the prevalence of coronary disease. I know there's no audience response system, but I figured since it's late in the day, I have to make sure I keep everyone awake, and we can either yell an answer or I could look for a show of hands. But as related to the time to resuscitation from out-of-hospital arrest, the chance of survival to hospital discharge, and this is drops by what percentage per minute, looking at the delay of defibrillation in particular, is it 0.5, 1, 2%, 10%, or 50% per minute? 10. Okay, and that is the correct answer, so that's wonderful. So this really emphasizes the urgency of resuscitation. So this particular study looked at survival to 1 month relative to the time delay. So you can see that if you go after 6 minutes or so, later than 6 minutes, the survival rate is well less than 20% and really drops off. So it's important to get there rapidly and defibrillate. So what is the mechanism or the etiologic basis for sudden death? Well, in the United States, most of it occurs due to coronary disease, about 80% either from a chronic scar with evidence for substrate in the myocardium from an old infarct, or acute plaque rupture or thrombosis with acute infarction can also cause that, or ischemia. Cardiomyopathies account for about 10 to 15%, dilated cardiomyopathy more commonly, or hypertrophic cardiomyopathy, with the remainder related to either ion channel defects or other things like congenital heart disease, drug failure, arrhythmia, other problems like that. So what are the triggers? So someone who has a substrate or underlying ischemic disease, what are the triggers? Well, ischemia can certainly trigger sudden cardiac arrest, electrolyte abnormalities, worsening heart failure, antiarrhythmic drugs, even in the absence of underlying structural heart disease, drugs that prolong the QT interval, even non-antiarrhythmic drugs that do that, exercise or other causes of sympathetic nervous system activation, things like emotional stress or anxiety. So after you have these triggers, often you may get increased ventricular ectopy in some patients with the occurrence of monomorphic VT that can degenerate to ventricular fibrillation and subsequent asystole. So you can imagine, depending on when you get to the patient, if you may see asystole or you may see an earlier rhythm. There are cases, of course, you can get primary VF as the initial arrhythmia. that can become finer and then eventually more asystolic. So then earlier studies in particular would point to VT followed by VF as the most common mechanism, primary VF or polymorphic VT or torsade, even in the absence of structural heart disease. So these are these shockable rhythms. Radioarrhythmias in asystole and pulseless electrical activity may have an increased occurrence now than there were years ago, but these can be related to certainly pump failure, PEA, or pulmonary embolism. Depending on what study you look at and where the study was done and what population of patients. This was an old study from 1989, just looking at patients wearing Holter monitors who happened to die. And you can see that almost all of the patients had a shockable rhythm, but obviously they had a Holter on for a reason, and that is a little bit of a biased sample here. Contemporary AED studies, automatic external defibrillators, show something a little different. So shockable rhythms in public locations, anywhere between 40 and 79% of patients you may see shockable rhythms initially. Casino study was about 71%. In the airlines, a little bit lower. Again, some of those are in the terminals and unwitnessed arrests. In the home, you can see a lower rate of VT-VF rhythms, probably because it takes a longer time to get there, right? So if this is one study looking at, this is the 1980s versus 1990s, you can see that there was a decreased occurrence overall, a trend toward, or significant difference towards the end of the study here in VF occurrence with an increase in PEA. That is relevant for a lot of reasons in terms of successful resuscitations more likely to occur with VT-VF than with PEA. In addition, so this particular study also looked at the percentage. Again, these are relatively low percentages, 30% over here, and maybe up to 40 or 50% of patients were actually got to the hospital alive, and a lower percentage again were discharged alive, really less than 20%. And these are witnessed arrests, bystander-witnessed arrests. So unwitnessed, you're even worse off. So another question, now if you have an implantable defibrillator, what's the chance of survival after an episode of VT-VF? So you have a device in, maybe it was put in for primary prevention. Is it 50%, 75, 80, 90, or 99? What do you think? Great. So this is to build out, there's a big difference, and obviously we know that, but just to emphasize why we want to think about prophylactic ICDs, or one of the reasons. So if you have a cardiac arrest, we did talk about one of the factors, or some of the factors that influence outcome. So if you have VT-VF, you're better off than if you have pulseless electrical activity or asystole. Younger patients, as you might expect, do better. Sex, after adjusting for differences in the occurrence of VT-VF, which will be more likely to occur in men at the time of out-of-hospital arrest, women actually have a better chance of resuscitation, whether that's due to body size and effectiveness of CPR or defibrillation, I'm not sure, but time to collapse is key. So you need to get there quickly. The quicker you get there, the quicker you defibrillate VT-VF, the better off you are. CPR may have some role, and the location, a public area, again, more likely to be witnessed and effectively defibrillated than at home. This is just one or two of the studies actually looking at the airlines, having AEDs in the airlines. So this also included not just on the plane, but at the terminal. You can see here that in this study, 22% had a shockable rhythm, compared to 44% in this study here. Non-shockable rhythms in both studies. The chance of making it to surviving to hospital discharge was 0. So the only patients that survived were those who had shockable rhythms in these studies. If you had VT-VF and these were AEDs applied, 33 to, I think that says 36% or so, or 38% made it to survival to the hospital discharge. The best place to have a cardiac arrest is in the casino, I guess, because they're looking at everyone, so if you're going to die, that's a place to die. And if you look at the percentage of patients who survived to hospital discharge were 38%. If you look at VF as the initial rhythm, it's 59%. And look how quickly people got there, right? With the AEDs, 4 minutes on the average, 4.5 minutes to get defibrillated for the first shot. I thought was pretty impressive. Now, unfortunately, Most arrests do not occur in public places. This is just one example. In the home or residential locations, studies will say 70 to 79% occur there. So because of that, the thought is, with this particular trial, HAT, the Home Automated External Defibrillator trial, was a really good thought. Gus Barty put together NIH trial looking at over 7,000 patients who were trained to either were randomized to either home defibrillation, you have half the patients got AEDs, and the first response should be to put that on, and then activate the emergency response system versus just doing the EMS call, the emergency 911, and then do CPR. In this study, only 36% of the deaths were related to sudden cardiac arrest from tachyarrhythmia in home. This was in the home, obviously. And a lot of them were in the home. And 117 were in the home. AEDs, unfortunately, were applied in only 32 patients. So there's a lot of different issues related to this, and probably, maybe it was partially training. There was a formal training with the patients, but they're intimately involved with their loved ones, or maybe there was no one else at home at the time, but the defibrillators really weren't applied. So even, I think they said even doubling the number would have really impacted on the results. So it's not that the AED didn't work, it's just that it wasn't applied most of the time. I want to just briefly mention, because this is something actually that really saw a lot of. I was over at University of Pennsylvania for 12 years and actually moved to a different site in New Jersey now for about 2.5 years. And it was very active. The critical care unit there was very active. And one of the things that they've been very active with is use of therapeutic hypothermia. And this is, the goal is to, after you have a cardiac arrest, if you're still comatose, you cool the body, and you aim for a temperature of about 33 degrees centigrade or 92 degrees. Different protocols use different duration of therapies, but about 12 hours. And then you gradually warm the body, and the purpose is to limit cerebral damage. This is actually, there have been 2 randomized controlled trials that have shown an improved outcome. I think they were both published in the New England Journal. As I recall, there's a relatively small number of patients, but randomized to either cooling or not cooling, and did show that they had a better neurologic recovery and a better survival if you had this cooling performed. And this was with initial DF documented. Now, there's uncertainty regarding whether you apply it to patients who have had out-of-hospital cardiac arrest. With initial asystole or pulse-selective activity, we tend to do that, but there's really not a lot of data to support that yet. But there's more investigation going on. The best method, the timing, do you use pooled fluids? How do you actually do it? Pooled bladder fluid, how you do it exactly varies, but we'll find out more about this in the next few years, I suspect. This is just a study looking at a larger number of patients. Again, it's a retrospective observational study, but a lot of hospitals are using this now, at least in the ICUs or sometimes in the ER. Maybe even potentially considering doing this, starting it in the field. But if you looked at patients before or after institution of the hypothermia protocols, it looks like there was a 20% reduction in hospital mortality. Again, it's different historical controls, but not controls, they're just historical observational comparison, but it does seem to at least support what the small randomized trials have shown. So after you survive, now what do? So you bring the patient in the hospital and you're working them up for other causes, so you want to exclude any potentially reversible causes. Infarction, ischemic disease that might require revascularization, electrolyte abnormalities, and remove any potentially pro-arrhythmic drugs. And then you want to prevent it from happening again, right? Whether you vascularize or not, if they have this in the setting, in the absence of an acute infarction, therapy would include secondary prevention with an ICD. And that's fairly standard. I'm not going to go through the details. This will be in the electronic, we have it in the electronic handout when we get that. But just to say, these are 3 the trials, secondary prevention trials from the 1990s. AVID was the one done in the United States, antiarrhythmic drugs versus implantable defibrillators, randomized class 3 antiarrhythmic drugs versus ICDs in patients who had a documented sustained ventricular arrhythmia, VTVF, and showed that there was improved overall reduced mortality in those who received an ICD. Fairly standard. There was a meta-analysis of all 3 studies, again showing that the combination, again, ICD reduced overall mortality, and as well as arrhythmic death, and it was almost entirely due to the 50% reduction in arrhythmic death with an ICD, as you would expect. In addition, the patients who had a lower ejection fraction of 35% or less benefited more than those who had a higher ejection fraction. This is subgroup post-hoc analysis. And then if you're back in the 1990s, some of the patients had thoracotomy devices, but a subgroup analysis also showed that patients who had transvenous devices benefited more, presumably because the risk of an epicardial procedure to put a device on is higher. The indications, again, these are just out of the 2008 guidelines, but for secondary prevention, they're also in the earlier guidelines. Class 1, again, a high level of evidence A, that ICDs are indicated after cardiac arrest or hemodynamically unstable VT after excluding completely definitively reversible causes. Again, this one here says a little lower level of evidence for those who have normal or near normal LV function, but unassociated with an acute infarction. Even if your LV function is normal, that is an indication for an ICD. So I want to talk a little bit about this sudden death, and I always like this. This is a schematic. You've seen it probably in many different forms, in many different publications. Dr. Meyerberg put this together many years ago, looking at an estimate of the incidence of sudden cardiac death on this side, and then the total number of events per year in the U.S. adult population. So the overall incidence is estimated to be 0.1 to 0.2% per year, representing somewhere between 300,000 to 400,000 sudden deaths per year. As you get into the higher risk groups, you have a higher incidence, a greater incidence, but a lower number of events. If we look at our primary prevention trials, we focus in this kind of group, the people who have already had an event. But we have to remember that we're really just taking care of a smaller group of our population, and we're missing a lot of people who still die suddenly. We're just looking at the highest risk group of patients. So how do you figure out who to study? So when you went back and you say, well, I'm going to look at the mode of death in people who have heart failure. This is a beta blocker trial. So the mode of death in patients who have class 2 or class 3 heart failure, 60 to 64% of patients who died suddenly. Whereas if you have class 4 heart failure, you're more likely to die from pump failure or heart failure. So if you're going to do a primary prevention ICD trial alone, you're going to look at this group because you're going to need to enroll less patients, right, to get the right number, to get a statistically significant difference. Whereas if you're looking at CRT therapy, to look at class 4, maybe include some of those class 3 patients. Ejection fraction is one of the markers for risk stratification, right? So this is in the pre- and post-thrombolytic error. You can see that EF cutoff of 40%, less than 40%, tends to go along with a higher mortality. So in addition to ejection fraction, functional class, the presence of ventricular ectopy can be an independent risk factor. Frequent ventricular ectopy or non-sustained VT is also used as an enrollment criteria in some of the studies. Other non-invasive markers, I'm not going to go and talk about much of that today, but EP testing was initially used in some of the earlier coronary disease primary prevention ICD trials. And this is basically in some of the older studies from the 1980s showed that EP testing can help with risk stratification. So if you go in the lab and you give some extra beats and you induce VT, and then you try to you get them out of VT by pasting or cardioverting them, and then you try to give them the drug and you try to induce VT, that would be the old way that we try to look at drug efficacy. And the first couple of trials, including MUSTT, which is the Multicenter Unsustained Tachycardia trial, initially performed by Dr. Buxton at the University of Pennsylvania at the time when he started it, looked at coronary disease patients with an ejection fraction cutoff he used was 40%, at least 3 beats of non-sustained VT, and to be eligible for randomization, we need to have inducible sustained VT and EP testing. They were randomized to EP-guided antiarrhythmic therapy versus just standard therapy that we would use otherwise, not antiarrhythmic therapy. And at that time, again, it's a while ago in the 1990s now, EP-guided therapy started with antiarrhythmic drugs, and you usually try at least 2 antiarrhythmic drugs, and if those didn't work, you can go on to an ICD. This is the control group. Now, on the y-axis, you have events here. So the control group is no anti-arrhythmic therapy and no EP-guided therapy. Here's EP-guided therapy divided up into those who received a defibrillator and those without a defibrillator. The only patients who benefited were those who received an ICD. This is MADIT 2, another coronary disease trial. This time, EF cutoff was 30%. You didn't need to have a PVC. Again, a lot of patients did, but you didn't need it for enrollment. You did not need to have an EP study. This was terminated prematurely. Oops, sorry. And you can see here that the curves separate rather early, and patients, again, survival on the y-axis. Those who received a defibrillator had a significant overall risk reduction compared to conventional therapy, and this was all related to a reduction in arrhythmic death. I'm showing this only because it's kind of an important point nowadays in terms of what we hear about with reimbursement and CMS and Department of Justice investigations, but I don't think many of us really think of the enrollment criteria for the studies. Now, in MUST, you could be enrolled if you were at least 4 days out from revascularization or MI, whereas some of the other studies use 3 months. And we hear a lot of that 3-month number out there right now. Also, the mortality rates in the earlier trials here were a little bit higher than we see nowadays, just because some of the other medical therapy may not have been followed very well, like beta blocker and inhibitor usage. This is SCD-HeFT, again, one of the bigger trials that really changed some of our guidelines. So this included non-ischemic patients, not just coronary disease patients. EF cutoff was 35% or less, and you needed to have heart failure. It's a heart failure trial, class 2 or class 3 heart failure. ICD therapy shown in pink, mortality on the y-axis. You can see that defibrillator therapy resulted in a reduction in mortality compared to placebo in yellow. It was a 1-to-1 randomization. Amiodarone was the other arm. The amiodarone did not do anything. This is just an overall schematic showing the reduction in mortality with the ICD, the coronary disease trials that use EP testing, a little higher overall reduction in mortality. Again, this will be in your handout, but just to show you a timeline of the different studies, SCD-HeFT was the largest study, over 2,500 patients with the longest follow-up. EF, we've gone through, most of them are like 35%, MADIT 2 is 30%. MUST was 30%, and here it's look at the highlight again. Not very good medical therapy earlier on, ACE inhibitors, beta blockers for the earlier trials, but we did better later. So ICDs clearly saved lives in primary prevention. So what about the timing of it? And that's a lot of what we're hearing about nowadays, right? Particularly over the past 6 months. What do we recommend? And we know that defibrillators do not appear from the studies we have to benefit patients very early post-infarct. And here's the data. This was from Dynamite. It was a device company-sponsored trial looking at the risk of death from any cause if you received an ICD within 6 to 40 days post-infarct. Enrollment criteria included an ejection fraction of 35% or less, and this marker of autonomic dysfunction, depressed heart rate variability. No difference if you received an ICD. Another one was IRIS, similar. Now it was followed for 31 days post-infarct. You had to have the marker for sickness, I guess, was a resting heart rate of greater than 90 beats per minute on initial ECG or non-sustained VT or both. No difference in overall mortality in those who received this early ICD versus those who did not. Although if you look at the primary endpoint was overall mortality, but you did reduce arrhythmic events, arrhythmic death, but it was outweighed by the other causes of death. And this is, I show this because I do get a lot of referrals from cardiologists. They say, I don't really know if I should send this patient. He's done well for 5 years or more, and he had his infarct and he's doing great. I don't know if he really needs an ICD, but his ejection fraction is still 25%. What do you think? Well, it's actually quite interesting that if you look at a subgroup analysis of MADIT 2, those who received therapy with an ICD did not, there was more benefit if you were further out from your infarct. This is 18 months or more from the infarct. So it's sort of the opposite of what you think. So you benefit more, maybe you die, if you're going to die, you die from other things early on, and then you see the benefit later on. But the curves are really separated out here quite a bit. So the indications, again, these are going to be inherited. They're written in the 2008 guidelines. There will eventually be another update in the near future for the guidelines, but looking at class 1 high level of evidence indication for ICDs, 35% EF or less. These are coronary disease patients, prior MI, but you have to be at least 40 days post-infarct. In addition, you can have here, so if you have the 30% number, class 1 indication, a little lower level of evidence because you don't have multiple trials, you just have MUST, looking at that in some non-randomized studies, but looking at non-sustained VT and inducible sustained VT or VF or EP testing. Class 1 indication for an ICD. And the non-ischemics, again, in the SCD-HeFT trial, class 2 or class 3 heart failure, 35% or less, class 1 indication for an ICD. In a smaller trial we didn't review, but you didn't have to have class 2 heart failure, you could have class 1 heart failure, but a lower level of evidence for implanting an ICD. So we've heard a lot about this. Now, what's going on? We have all these doctors, the ET doctors are putting in devices and they're not indicated, right? Non-evidence-based indications for ICDs. So are we really implanting too many ICDs or are we implanting too few? Because we talk about underutilization, people aren't putting in devices, and I think everyone's all confused with all these, the bad, media out there for the bad information, some of the bad information out there about the high occurrence of lead failures and all these other things that have not really helped our patients, I believe. So we know that few lives are saved after you have a cardiac arrest, so we know prevention is key, right? And we know that there are multiple randomized trials. There's not a lot of places that you've had these large multi-center trials looking at this therapy to show that defibrillators work for primary prevention. So what is the appropriate use of ICDs in 2011? And what is the rate of compliance with the guidelines for ICD implants? And is it ever appropriate to implant devices outside the guidelines? I'm going to ask the audience again, according to clinical data, and it's not just administrative data anymore from billing data, this is clinical data, approximately what percentage of patients who are eligible for ICDs based on the guidelines actually receive ICDs? Is it 95%, 75, 50, 20, or is no data? Any guesses? All right, surprisingly, it's 50%. And this was, when this study came out, I said, wow, this is really quite amazing. It's higher than I thought, too. I would have guessed 20%. This is a very nice heart failure study called IMPROVE-HF. It's a prospective cohort study to characterize the management of patients with chronic heart failure and an EF of less than 35%. This is just a part of the study. It was mostly guideline-based treatment, but they also looked at ICD utilization. And EFs were 35% or less, and there were chart extractors that looked at over 15,000 patients in 167 practices in the United States using the standard criteria we talked about for a high level of indications for ICDs. In those 7,000-something patients who were eligible based on the guidelines, only 50% received an ICD with or without CRT therapy. And I thought this was amazing, the variation in use by practice. Now remember, these people are participating in the study, highly motivated group of practices. And you can look down here that some practices are way down here, almost never implant an ICD, and other practices always implant an ICD. So that variation, it really should put up a red flag. Something's going on, right? So if you look at a multivariate analysis of what goes along with adherence to ICD use, so adjusted analysis showed that it was a lack of adherence by advanced age. You might expect that. Maybe they have other comorbidities you can't control for everything, but lack race and lack of insurance and an increased adherence for male sex, ischemic disease, a northeast location, you live up where there's so many electrophysiologists in the Philadelphia area per capita, or if you have an EP doctor on staff. So is this a education issue? Maybe. Or is it really an access to care issue, a patient access issue? So these are important considerations we need to think about. This I found surprising. So this was just published in non-journal. This is just from a search I found, 2010. Never read that journal before, but this is a survey of primary care and cardiologists in the Rochester, New York area. relatively recent, again, well after the guidelines were published. 33% response rate for surveys, I'm told that's pretty good. And 17% reported unawareness of that there were even guidelines for ICD use. In 2008 wasn't the first time we had guidelines, 2002, we had them for a while. And these are primary care and cardiologists. 59% recommended ICDs in patients with ischemic disease, and an EF cut up of 35%, 62% if they had non-ischemic disease. And as you'd expect, cardiologists were more familiar than primary care doctors with the EF criteria. And 76% believe that the ICD can benefit patients that were 70 years or older. So a lot of people didn't think. 24% thought that if you're 70 or older, it's not going to benefit. So, and none of the trials really had that age cutoff in them. So, included some patients who were older. So, there's still obviously lack of familiarity with the guidelines, and so there's clearly a lag in practicing what the guidelines say and adherence to the guidelines. And because of that, and I'm not sure how many people in the room are very much involved in performance measurement, but there's been this push towards development of performance measures. I have a good amount of first-hand experience with the National Quality Forum and been involved in some of the QI work with the American College of Cardiology and Heart Rhythm Society, doing some committee work. So basically, what is it? So we have clinical practice guidelines, just to give you a general familiarity. We make performance measures that are being developed by Heart Rhythm Society right now, as well as ACC has been developing these, and this helps to quantify adherence to the guidelines and is a way to measure and improve the quality of care. We measure performance, educate to alter behavior, and re-measure performance. And this gives you an opportunity to improve it. Because sometimes just looking at what you're doing with anything, if you have an infection with a device in your lab, then you kind of look at the process of what you're doing. So just looking at it sometimes helps change it. And then you can improve the next time around. And with all the changes in healthcare going on, there's more and more talk, and we're going to be reimbursed for quality or value as opposed to just quantity. So there's perhaps some good to part of that. I would suggest a disconnect between the guidelines and CMS reimbursement. For an example, this is a case of a 74-year-old male, old anterior infarct, old stent to the LAD many years ago, had a low EF post-MI and delayed to revascularization, no significant improvement in EF over time, just changed his source of medical follow-up, cardiology follow-up to the University Center. And then came over to the angina with a new marginal lesion. PCI to the OM was recommended and actually was performed. So it's surprising to say that if you implant an ICD during the same hospitalization as you do the PCI or within 90 days, this would not be covered by Medicare, and in this situation, it's actually considered fraud. So it seems weird because we don't really think that doing something to the marginal is going to do anything to the anterior wall right now. I don't think so. And there are coverage decisions, so this whole Department of Justice investigation is really based on the 2005 CMS NCD, which states that you're eligible for an ICD with certain criteria, but not if you've had CABG or PCI within the past 3 months, and not if you've had an acute MI within the past 30 days. So I suspect that most of us don't really actively read, and it's actually different for different payers. We don't go and read what the regulations are. We just do what we think is clinically appropriate based on the guidelines for our patient. I'd also suggest that maybe there are some gaps in the guidelines. For example, things that we can't really address every single scenario in the guidelines. So this is a case of a 56-year-old gentleman with a remote anterior wall infarction, low EF, and came in with a non-escalation MI, didn't really have any revascularization performed back then, and had 3 vessel disease, also severe mitral regurgitation, had CABG and mitral valve replacement performed, and developed complete heart block post-operatively. So then you as the physician, cardiologist, or electrophysiologist seeing the patient are going to make recommendations. Do you implant a pacemaker or do you implant an ICD? So if you implant a pacemaker, you still need a pacemaker, you can't go home. So, might this get better? In the best of all scenarios, we wait 3 months, repeat his EF, you can put an external vest or some device to protect him if you want during that period of time. But, now that he needs a pacemaker, I think most of us would say they're going to give them an ICD up front rather than to put them under risk of having another device in 3 months, and the increased risk of extraction should be easy, but still there's a risk of infection. There is something called appropriate use criteria. I've gotten involved in this more recently. It really exists for a while with non-invasive testing and revascularization, so a lot of you may know a lot more about these than I was aware of about 6 months ago. It utilizes clinical scenarios to mimic common situations encountered in everyday practice. So we evaluate the appropriate use of a procedure defined as a situation where the expected benefits related to survival or other health outcomes outweighs the negative consequences of the procedure. So the procedure is thought to have value. And this is currently being developed for ICDs and CR2 devices. So as some take-home messages, I want to emphasize, number one, the best treatment is prevention. I think we all feel that that's probably the best thing overall. If we can prevent heart disease to begin with, that would be ideal. Putting on a fat content at McDonald's in calories probably will help somewhat, but we have a long way to go. Despite improvements in resuscitations, most patients still will not survive the sudden cardiac arrest. Although the recent media focus has been on the overuse of ICDs, clinical performance data supports underuse. This is clear. So might there be some inappropriate use? That's always possible. I think we have to find out more about that. But we are clearly not putting in a lot of patients who really potentially deserve and can benefit from it. However, we have identified disparities in ICD therapy, and this needs to be addressed. It should not be based on insurance or race or location in the United States. A large body of data supports ICD uses for primary prevention, as you've seen. I showed you some of the clinical trials and the Class 1 guideline recommendations with a high level of evidence. We need to clearly improve this stratification, and this is key. Instead of implanting, depending on the trials you look at, it's either 1 in 4 or 1 in 13 or so, 14 devices to save one life. We want to be able to have an improved cost-benefit ratio, but we need to improve risk stratification. And remember that Bob Meyerberg graph showing that most of the patients we're still not even touching, most of the patients that die suddenly are not in those highest risk group of patients that we've been studying so far. So these genetic kind of markers will hopefully help us in the future to really identify the arrhythmic death risk in the general population. We clearly need additional education regarding the guidelines and performance measures for physicians and other healthcare personnel to provide ICDs for all patients who may derive the greatest benefit. So I want to thank you and answer for any questions. I don't see any lights flashing. I'm supposed to see it somewhere.